Today's microlearning is about stunned neurogenic myocardium. Stunned neurogenic myocardium basically means you have primary myocardial injury secondary to a neurologic event or a psychiatric event. It's called by different names like Takotsubo's cardiomyopathy, reverse Takotsubo's. So the pattern of wall motion abnormalities that you see on echo is different from what you would see with classic coronary artery disease. Theories behind why you get stunned neurogenic myocardium is a couple of different reasons. One is they think the coronary microcirculation has pretty significant vasospasm during these phases. That's what's responsible for the unequal distribution of wall motion abnormalities. The second thing is a lot of these conditions have significant catecholamine surges. And when you have a catecholamine surge, it can actually wipe out your beta receptors on your myocardium. And the beta receptors are not uniformly distributed. So if you have a higher concentration of beta receptors at the apex, then that is going to be the area that is going to be more frequently affected by the wall motion abnormality based on this pathophysiologic mechanism. These are some of the theories about it. So when we look at the diagnostic criteria for stunned neurogenic myocardium, the current criteria is the Intertac or the Mayo criteria. So you got to have LV dysfunction, whether it's apical or one of the other variants. You got to have no obstructive coronary artery disease. Your LAD, RCA, circumflex should be okay. New EKG changes, typically QT prolongation, T wave inversions is what you see, and there should be no other reason to explain these changes like myocarditis, pheochromocytoma, etc. Speckle tracking echocardiography is much more sensitive than 2D echo in looking at myocardial damage in patients who have stunned neurogenic myocardium. When you look at speckle tracking echo, the entity that we follow most frequently is called the GLS or the global longitudinal strain. Normally, that value of GLS should be about -20 or greater. In the more negative that number is, the better is the function. The less negative it is, worse is the myocardial function. So in patients with subarachnoid hemorrhage, say for example, who have severely impaired myocardial function, that GLS can be as low as -10, -12. So when we look at speckle tracking, you can also track the recovery of the myocardium over a period of time. In the acute phase or the hyperacute phase, when patients first present to the emergency room or to the ICU, the GLS can be very very low, like -10s or so. Within the first couple of weeks, you will actually see improvement in the ejection fraction and myocardial contractility, but it's still not completely back to normal. If you follow speckle tracking over time, you can see that it takes 6 to 8 weeks or even much longer than that to actually have recovery of myocardial function. The other important reason for using speckle tracking is to use it as a risk stratification method for other myocardial complications like LV thrombus, etc., in patients who have pretty significant cardiac injury after neurologic disease. Thank you for watching and catch us on another episode of QOD Microlearning.